Cheers, Jyoti.
Thank you, Will. Thank you. So, I'm Jyoti Srinivas. I'm a consultant pediatrician working at Milton Keynes Hospital. Before I start my lecture, I want to make it clear, you know the graph that Will showed of exam percentage, and he pointed at Patrick and me and said, weirdos, I'm definitely not one of them, okay? And I have seen your questionnaires. How many of you have given it once, MRC-PCH exam? How many of you have given it twice? How many of you have given it 3 times? How many of you have given it 4 times? There, see? So when I met Will, I had just passed my exam, part 1, after a lot of hard work. And then he came up to me and said, Jyoti, would you like to write some questions? And I said, would I? I'm an expert now at this exam. I know all the questions that's there, and I can do better. I then realized how difficult it is to write questions. So I have been with question writing groups. Now for the last few years, I'm on the ANGOF group, where once you write the exam, we set the pass mark. So we go through each question. And sometimes there are some questions that slip through, and you think, oh, this is too confusing for at your level. Or we think, there are really 2 answers for this, and it's fair they got confused. So we take those questions, or we say, let's adjust the marks for this. So the questions are getting better in the last few years, I can say, definitely. And we've taken out all the ambiguous ones, the true or false ones, all the ones that we think, should they really know this? And what's the point of you knowing this? So it is getting better. So I think that's one of the reasons why Will has asked me to speak here, because I know the questions and I know what should be there. The second thing I need to tell you about... This one? Yeah. Oh. Nice. Okay. As Will said, this is not an easy topic, and we know you all find it very difficult to prepare for this topic. And one of the main reasons is this topic has improved, or rather a lot of research has been done in the last few years. Probably from when Will gave the exam, or I gave the exam, it was a simple chapter. Now there are volumes of books written in it. So I'm not going to cover everything of this in the next 1 hour. What we are going to try and cover is what you need to do at your level. So as an ST1 or 2, if you're talking to an immunologist, can you at least get the basics to say, I understand a bit of immunology. I think I know which part of the immune system we need to investigate a bit more. And of course, what you're all here for, what you need to know for the exam, what questions are going to come. Okay. Now, Will did say when he gave the exam, he did know what is chronic granulomatous disease and what was hyper IgE syndrome, but I suspect that was the height of his immunology knowledge at that time when he gave the exam. But at this stage, you need to know a lot more. Okay. So this again, as Will was saying, this is the Wordle. Before, we used to be everybody ticking IgE mediated, mainly because if you have a choice between IgA and IgE, you'll always pick the one you sort of know a bit. So IgG or IgE came up the most common ones. So you can see these are the ones that came out quite frequently. So we'll try and cover a few of these here. So what I am going to cover here is a basics of immunology or our immune system, things that go wrong, which don't work when they should, common immune deficiencies, and you have to know a few of these syndromes, and in the last about hypersensitivity reactions. So in terms of what I want you to understand today is when to suspect immune deficiencies in children, how you go about investigating them, and if you do see some of the common immune deficiency problems in children who already have a diagnosis, you have a fair idea what it means at this end. And these are the ones that the questions will be based on. I'll give you a few seconds to read these 2 questions. You don't need to answer them now. Do they sound fairly similar to the ones you might get in the exam? Yeah. Is there anybody who thinks this is quite easy? I can do this. Then you probably don't need to be here if you know this. Okay? But we'll come back to the same questions at the end and see if you can make sense out of these. So, as is pointed out, I'm not an immunologist, but I have worked with an immunologist for a year. So we're going to go by simple rules, simple definitions, break it down into small chunks, and look at the things that we need to know. Okay? There are lots of, tables, lists, all over different countries of when to suspect immune deficiencies. The things that come out quite often is they usually have a strong family history and they have a faltering growth. So if you see a child with faltering growth, one of the things you have to think is this child got immune deficiency? Okay. And they have recurrent or serious infections. Sometimes the type of organism, as we go through future syndromes you'll see, may give a clue. And the age of the child also matters. When they're younger, they're more susceptible to some kind of immune deficiencies. When they're a bit older, you think probably these types ones. So we'll look at them. Again, there are different diagrams for this. This is the one that I like. This is a simple way of understanding how our immune system works. So I look at it as 3 levels. So the outermost is the easiest to understand. This is the anatomical and physiological barriers. So what it has is your skin, which prevents lots and lots of microbes and bacteria getting into you. You need to have your tears and saliva to wash out. You need to have a very strong ciliary mucoclearance for your lungs to trap those things. You need to have very low stomach pH so that all the food or anything you ingest can be destroyed. So these are your first level that stop you getting infections. So that's why you understand children who have burns, so their skin barrier is broken, who have cystic fibrosis or other problems, it's easy, or they have central lines, or they're intubated, they're more susceptible for infections. So this is your first line of defense. The second line is innate immunity. So this is by neutrophils, by macrophages, and complement system. What it does is those bacteria or viruses that pass through your first barrier, this is a quick response, so it's a rapid one, but it's non-specific. So it produces lots and lots of things to fight off this infection, but they're not very targeted, but they're quick. The last one you have is adaptive immunity, which is made up of T lymphocytes and B lymphocytes. And these are very specific, so they produce antibodies that can act very quickly against a particular type, and they are very efficient. Okay? So that's all you need to know, basics, 3 lines. Okay? So when we have something that does not work, as in the previous slide, then we can classify them into different ones. You have primary immune deficiencies, so they are congenital, or you have secondary ones. Secondary are usually acquired, like malnutrition, drugs causing immunosuppression, HIV. Okay. What you understand with primary immune deficiencies, there is no easy way to give a list of things and say this is the one that causes it. They come in a wide range of presentations. So it can start off when they're born with some milk allergies, some other allergies, and going up, they get lots of infections. Then they can get into inflammations and then autoimmunity disorders. And they can even have lymphomas and malignancies. So they cover a wide range of topics. this is one of the main things that I learned after 1 year working with immunologists. All you need to know to suspect immune deficiency is these 4 things. They're called SPUR. So the first one is serious infections. What do we mean by serious? That means they're potentially life-threatening ones, like meningitis. Okay? Or when a simple tonsillitis becomes a quinsy. So that becomes life-threatening. So you think, why has this child got to this stage? Next is persistent infections. So you know this infection. It's a urine infection or a throat infection or chest. You've treated with what you think is appropriate antibiotics, and it's still not going away. So a week of amoxicillin for chest infection, and you think, why has the child still got symptoms? Why is it not getting eradicated? So that time you start thinking, why is this still persisting? Are we not treating it right, or is this not enough? The third thing is unusual infections. These are infections where you think, why has this child got this infection now? Or they grow something in the urine or blood culture, and you think, what is this strange bug that we don't expect to see in this child? The last one is recurrent infection. These are different from persistent infections. Recurrent ones is they get an infection, you treat them, it seems to get better, but it comes back again. So what has happened is all the bacteria or the viruses have not been completely eradicated. So they're still there, a little bit of it. In a few days, they multiply and come back again. So these are the 4 main things. So if you get a history in a question about a child who's having any of these ones, you're thinking already, is it pointing towards an immune deficiency? And I've said again, if they're related, consanguineous, so family history is very important. And if they have faltering growth with any of these, it's guaranteed it's going to be an immune deficiency question. Okay. So very soon you'll be doing some group activity, because I know it can get quite boring with me standing here and talking everything about it. So we're going to concentrate on primary immune deficiencies here. There are different types, as you can see. We'll go through a few of them, and we'll come up to the combined ones where you put everything together. I will do one of these deficiencies, and then you'll have your group activity. So complement deficiencies. Anybody know what complements are? Yeah, C3, C4. What are they? What are they? They're sort of serum proteins. There are about 30 of them. Okay. All you need to know is if you have a complement deficiency, you have difficulty fighting encapsulated bacteria. And what are these encapsulated bacteria? Any answers? Anybody know any one of them? Strep pneumoniae, H influenza. That's it? Any more? So what did we get? We get strep pneumoniae, group B strep, H influenza, I think even Salmonella typhi, but that's one of the things you just need to remember again, encapsulated bacteria. The other thing you need to know in complement deficiencies is hereditary angioedema. And what do they get in this? They get recurrent episodes of severe swelling. So I've put some pictures, because you remember pictures better than just putting up some lines. You will get all these slides, I think by Monday, emailed all to you, isn't it, Will? Compass, yeah. So they'll all be there, all the slides. But you can write them on Post-its if you think you're learning something. Looking at these pictures, what does it remind you of? Any other condition which you should know to differentiate? Nephrotic, yes, yeah. Anaphylaxis, yes. So let's see if we can differentiate from anaphylaxis, because that comes up sometimes in exams too. So what's anaphylaxis? It's a sudden one, very good. Is it a mild one, or you think it's quite worrying? Life-threatening, yes. It's a sudden, it is life-threatening. Systemic, exactly. So it's sudden, life-threatening, systemic reaction. And it usually causes either airway, breathing, or circulatory compromise. One of the three, it has to be there. They don't always have to have urticaria or a rash. About 20% of them don't have an urticarial rash, but they could have anaphylaxis. Okay? And they may not have a history of allergies too. So that may be their first attack. So looking at this lady, let's say, and imagine her as a child, how do you differentiate this from anaphylaxis?
She doesn't seem to have any bleeding.
Yeah. She seems sitting there posing for a photograph. You think can't be that bad?
Although she might get it with hereditary angioedema.
She would, isn't it, soon?
we are coming back to hereditary angioedema because it's a lovely topic.
It is.
Some breaking stats. So I've got some stuff on hereditary angioedema as well.
Perfect. Okay. So I wasn't going to go too much into it. So it's autosomal dominant, so there's a family history of it. It usually comes later on in life. They usually don't have any history of allergy to it. With anaphylaxis, what works straight away? Adrenaline. What else do we give them? Antihistamines, some steroids. Yeah, we give all that. Do you think they might work here? No, they don't work here. Okay, so it's important to know, because there's no point giving them lots and lots of adrenaline if it's hereditary angioedema. Okay, so when you measure their blood tests, they have low C1 and C4, complement 1 and 4. So you need to know that. There are different types of hereditary angioedemas, but I don't think you need to know all different types and everything. But this is the main thing you need to know. Okay, so what we're going to do is have some 5 groups, and you're going to write at least 2 or 3 lines or points on each topic here, and then we'll see if you get the ones. Because I can just put up slides and read it out, but you need to remember if you have read them already. So if we just go for ease of these, one group here, first 2 rows, second group, next there, third, fourth
So group 1,
row.
Group 2, Group 3, Group 4, last 2 rows, Group 5. There you go.
I thought they may not be able to talk from one end to the other.
Yeah.
You might have to shout it out, but yeah, that's okay. I don't mind.
We might have to. It's quite hard to get into. But you can
Yes.
do if you want. If you want to come across, into the sides, you might find each of 2 rows, and use one of these as a desk.
If you want to.
If Group 1 wants to go that way, if Group 2 wants to come this way, use these rows. Group 3 goes that way, Group 4 comes this way, and Group 5 goes that way again. You get yourself a line, and then you should be able to use one of these as a table. So Group 1, go down that way, Group 2, come this way.
Go on, we'll give you about 4 minutes to come up with as many points you think about each one. So if you pick group 1, whoever you are, if you pick chronic granulomatous disease.
Yeah?
Group 2, hyper IgE.
Oh my God, yeah, okay.
Group 3, DOC8 deficiency.
Good luck, Group 3.
Group 4, Wiskott-Aldrich syndrome. And Group 5, if you can decode what LAD is and write 1 or 2 lines, I'll be very happy with it.
Shouldn't take that long.
Shouldn't take.
All right, go on, Group 3, go on over there.
Go on, quick. Yes.
Always difficult. Always difficult.
Yeah.
It's layouts and the status.
It's either this or I had to just put up slides for them. So yes, we'll see. I might make them stay in their groups because I have another small group session. Once we finish these 5, I have another 5.
Cool.
So they can just stay where they are. Yes. Oh, thank you. How is she? Oh.
embryology.
Oh, yes, I did see. Next time I might just come and sit and listen to all of them. I think I've forgotten most of these. Embryology, remember? What?
Patrick's brilliant. I mean, it's just wonderful because it's understanding it rather than just that. We learnt it as a list.
We just learnt it, yes.
We just learnt it as a list.
That's
and
correct.
then you hoped it didn't come up. Or hoped we were able to pick it out of the list.
I hoped only Bartas came up. That's the only one I knew.
Exactly.
Well.
We all learnt Bartas and hoped it was Bartas. And if it was something else, if it wasn't Bartas, we said we guessed one of the others, didn't we? That was our management style.
That was. That was.
Have you seen this book?
No, I was going to take a photo of it and say, picture of it. Say, it looks
What
nice.
are we doing? We're doing immune system.
I have written my own article on how to investigate immune deficiencies.
Oh, brilliant! Where?
Archives.
Oh, fantastic! I just.
And I saw you've given it to Nottingham, somebody to write it for your journal.
It wasn't me who recommended them. It had been whoever was taking that journal. I didn't know you'd written anything. But no,
Look, it's the same stuff.
Liz McDermott.
Oh yeah.
But
yeah.
Liz is so good. I mean, she
Of
is
course.
really good. She gives
I wrote it with Scott Hackett.
Liz gives a cracking talk on.
Does she? Okay.
Pathology and immunology.
Ah.
And then we've got cytokines released.
Okay. I can't believe you take longer than this to write. I hope you don't know this much. So let's start with chronic granulomatous disease then. Which group was doing it? Okay, go on then. Let's see how many points you got across. What was it?
It's the one where the neutrophils fail to produce the superoxide radicals.
Okay.
So you can write.
So do you want to repeat that for this?
Do you want to? No? Oh, I'll repeat it. So it's the one you said. You're very happy. Yes, please repeat it. It's the one where the neutrophils fail to produce the superoxide radical. Yeah.
So they can like engulf an organism, but they can't kill it.
That's correct. So they can engulf the bacteria or organism, but they can't kill it. So they're just stuck there. So you get these abscesses everywhere with everything in the middle. Yeah.
So it's like Staph aureus, E. coli, Salmonella, the catalase positive.
Okay. Yeah. Staph aureus usually. Yes. All these abscesses. Any other points you got across? You get it off with.
You get an abscess after the BCG, and that can be the. Or am I getting that mixed up?
Probably a little bit.
Not necessarily.
Not necessarily, yeah.
Not necessarily. Did we talk about the test for CGD? So the neutrophil burst test. The neutrophil
NBT,
burst test.
yes.
Usually NBT, but it will be neutrophil burst test now
Yeah.
because some labs do it differently, probably in the exam when it comes up.
It will still be NBT then.
Yeah? No, maybe, but yeah.
Neutrophil birth test, yes. Yeah. Okay. So, what do you need to know about chronic granulomatous disease? It's a primary immune deficiency disorder. It's X-linked mostly, so males get it. Occasionally, it's autosomal recessive, so both males and females can get it. So, as we said very nicely, neutrophils are there, but they can't function properly. They can engulf, but they can't kill it. So they get recurrent infections and granulomas, so abscess, skin infections. And previously we used to have what we call a nitrosamine blue test. So it used to come back as a negative in this. Normally it should be positive, but it comes back negative. But now we do burst test. But there is a test, basically, all that you need to know to recognize this.
Yeah, so it used to be nitrosamine blue.
Blue,
but
now it's
neutrophil
burst.
So it's still NBT. I think you're trying to work out which one of the two it is. But in the exam, we'll now, I hope, call it neutrophil burst. But nitrosamine blue is a version of that test that comes up.
Sorry? Sorry, I can't. For blue test, the old one, it will be negative. For the new burst one, I suppose it will be, yes, reduced. Okay. So next one had hyper IgE or Jobs syndrome. What points did you come up with? Anything? Have you heard of it? Did you heard of it? Yeah? One person is nodding. That's good. Any points on it?
We said it must be congenital.
We thought it must be congenital. Okay. Should be. What does it say? Hyper IgE. So what do you think you're going to find? Loads of IgE, yes. So when you test them, they'll have high IgE. So what does high IgE do? You get allergies, atopy, so you get eczema, allergies, yes?
Can they have eosinophilia?
Can they have eosinophilia? What do others think?
Yeah.
They can. They should, isn't it? Yes, they usually go together. So when I worked with an immunologist, he said they have very typical facial features, and I find it very difficult to pick them out. But basically, it's almost like, when you have a metabolic disorder, you have mucopolysaccharidosis, you say sort of 4 coarse facies. I think that's all it comes up to. But I like this genetics because it can be autosomal dominant, recessive, or sporadic. Basically, it could be anything. But what they get is recurrent eczema, skin abscesses, and lung infections because it's all IgE. So when you test them, you have raised IgE and raised eosinophils. The rest of the immunoglobulins will be normal in this case. What do you do with these children if you see them? Good one, Rafa. And if you were sitting at an immunologist clinic, what would you do? Right. What can you do if somebody's got high IgE? What can you do? Not much. Yeah?
I mean, it's really high, so it's not like you can give omalizumab to get it down. Their IgE's in the thousands, so it's very, very high. And it interferes with B-cell signaling, doesn't it, Jyoti? I mean, that's the extra IgE interferes with the IgG and IgM responses. So there's my favourite line in clinic is, I don't know what the question is, Jyoti, but the answer is azithromycin.
You try azithromycin, yeah.
We tend to use antibiotic prophylaxis for them, they do a bit better. So certainly the ones I've got in my clinic are all on azithromycin. So, but that's the answer to everything, by the way. If it's there in the exam, it's probably the right answer.
So you can treat them, eczema and skin infections. You can put them on prophylactic antibiotics. But really, to bring the IgE down, it's quite difficult on its own. So that's one of the questions that comes. Okay. Now, what did we have next? DOC8 deficiency. Now, the third row. Have you heard of it before? No, I hadn't heard of it when I gave my exam, actually. I was surprised when it came up in the recent questions.
Yeah, well, this is new.
It is new.
That we do a bit of breaking science every now and again because we'll come to new things coming up. That 25% of questions will be new in every exam, ideally. And so we pick on new stuff that's been learned. And that's hard to keep up to date with. DOC8 is new. It's another, well, Jyoti might tell you, right? Have you got a slide on DOC8?
I have. As I had to remember to refresh my memory. I was like, I've not read this one before. But yes. So you all haven't heard it. Let's go to that. So it's autosomal recessive. Again, they come with eczema, allergies, asthma, recurrent infections, just like everything else. But what I find it for exam question technique answering is they get recurrent viral infections like shingles, molluscums, and warts. That seems to stand out a little bit. And they again have high IgE levels and eosinophils, but they do have low T and B cells with low lymphocytes.
Can I just ask, I know the other person said it as a joke about referral.
Yeah.
But one thing that I'm thinking when you're talking about this is that, you're sort of saying, unusual or recurrent infections. So say during a winter period, you get someone coming in, like frequently you get those coming back, and the parents are saying they've always got a cough and cold, they've always got this. So then do you take that in context with their weight and their general health? And at what point do you have
do you start investigating? So there is a list, there are a lot of lists. There's one which is called 10 warning signs. In that it says, if you get more than 6 or 8 infections when you're between this and this age, it should be taken seriously. But it all depends. When parents come and say they always get infections, what type of infections are they talking about? Is it once a year infection, next it was a cold, next it was a bit of DNV, next it was UTI, or was it always ear infections? And all these infections, do they need antibiotics, or do they just get better on their own? We see from the GP's referrals from pediatrics, at least 25 to 30% is the same question. Parents think there's something wrong with this child's immune system. They get frequent infections. Can you evaluate? And we have done an audit on it, and we can say about 95% of them are normal children. Okay? So we just reassure them. We'll come back to that slide to say how you investigate. What's the first line? You don't need a lot of tests. You only need very basic tests, and you can reassure them.
And the good news is we're drifting into AKP as an exam topic on that part. So this is becoming a little bit clinical, and that would be culled from the TAS exam.
Okay.
We're trying to move away from those. They've been put into the AKP paper.
Okay.
Although clinically very useful, so no questions about that.
It is. It's a very common topic.
Okay.
So I do this topic quite a lot to my junior doctors because they get this all the time.
Yeah.
Many child coming in. Okay.
Yeah. Doc8 is the protein, but it's also the name of the gene.
There are lots and lots of words in immunology like this. Yes, I've tried to avoid them all. So let's see, Wiskott-Aldrich syndrome. Now this has been there for some time now, so you should have heard of this, whichever group was doing it. Do you have any points on them? Very good. Low platelets, yes. Yes. So it's X-linked recessive. Males get it. Eczema, low platelets, immune deficiency. That is your standing out point, that they have bruising because they have low platelets in this. Okay. So what happens is there are platelets, but they're quite small. They don't function properly, so the spleen keeps removing them. They also have raised IgA and IgE. So you can already see you have a child with raised IgA, IgE. It could be quite a few things, but you need to know how to differentiate them in your questions. Okay. So what was the last one? We went about LAD, didn't we? And we said, let's see if you can at least decode it, the last group. Leukocyte adhesion deficiency. Brilliant. Any lines on it? Anything you know?
I only know that if it's there,
Yes.
the umbilical cord
Basically, that's all you need to know about it. It's a very, very rare disorder. It comes up quite often in exams. Don't know why.
But we will call it because it is incredibly rare. Yeah, it's incredibly rare. And it's the diagnosis that your SHO always makes because they always ask about delayed separation disorder. And it's like 1 in a million or something. It's incredibly rare.
It is, but I think it's one of those favorite questions exams, so it might slip through. So all you need to know is they have lots of neutrophils in them, but they don't work properly. So they do get a lot of abscesses and bacterial infections. But one main thing for you to differentiate is if anywhere in the history it says there was delayed separation of umbilical cord, then you're going through to this.
So the sort of question we'd ask now is what cell type enables separation of the umbilical cord? Okay? Because we're asking about understanding. And then we'd have a list and we go T cells, B cells, neutrophils. Do you understand how we're asking questions going forward? Because we're less interested in a very rare condition, more interested in your understanding of why we see that.
Okay. So that's 5 conditions. So this is a bit of summary. You have a child that they've given you with high IgE. If they're autosomal recessive, it's likely to be Doc8, the new one. If it's dominant and have coarse facies, then it's hyper IgE syndrome. If they have bruising, then it's likely to be Wiskott-Aldrich syndrome. And if it's just allergies and raised IgE, it's likely to be an atopic child. So it's important to remember that. Okay. Now, I have 5 more conditions, and we'll do one quick session again.
Well, maybe just speak to the person next to you. We'll do it a bit.
Yes, this might be quicker. We'll just give you about 2 minutes to see how much you know. And what I want you to pick out the points is the one that will enable you to either pick that exact diagnosis or it will differentiate from others. So important points. So you've got 2 minutes. I'll finish in 10 minutes.
Remember how to snowball? There's another way of doing it in this group. Sometimes you get 2 people and they say, right, get together in group of 4.
Yeah.
And then 8 or 10 until so it involves the whole group.
Yeah.
And then get one person in the group to feed back. So that you get everyone talking to make sure everyone engaged as the same small group work when you're in lecture environments.
Yeah.
I wonder about using that in the when you've got when you've got the same thing if you've got people trapped.
Yeah.
Rather than trying to get them out.
I see. We're running out. I'll finish in 5 or 10 minutes.
Whatever you want. It's fine. Don't rush it. It's fine.
Yes. Okay. Right. Okay. I can hear less and less chatter, so I think you're running out of things now already. Okay, let's go through. IgA deficiencies. So it's mainly in mucosal secretions. This is the most commonest type of immune deficiency. Okay. So when you check their immunoglobulins, they come with this, they might have immune deficiency, and you check their immunoglobulins, IgA is a bit low. The rest are normal. And most of these children are otherwise well. We probably haven't checked enough children, and they may be running around with IgA deficiency. Doesn't matter. Doesn't matter. They do get recurrent infections, allergies, sometimes chronic diarrhea. And as with any IgA, they're at risk of atopy and autoimmune disease. But if you don't check it, you probably don't know there are a lot of children with allergies going around with this. So this is the commonest, but we just observe and say, yes, it's a bit low. Keep watching. Ataxia telangiectasia. This is autosomal recessive. So this has got low or absent IgA. Okay, so there's a lot of blood vessel problems in this. So that's why I've put pictures for you to see this. And it's a progressive disease. So telangiectasia, you all know, it's some extra blood vessels going around. What's ataxia? Yes, somebody's saying yes. So it's cerebellar ataxia. So usually the children are a bit older. So they're not young babies. They're a bit into toddler stage when you start realizing that they have a bit of ataxic gait. So in your questions, if it's a baby 3-month-old, it's unlikely to be this diagnosis already. So they tend to be toddlers. This is one of my favorites, subacute common immune deficiencies. Anybody heard of the bubble boy? Probably not. You're all too young. I was probably born in that decade when he was there. So this is autosomal recessive but can be X-linked. The T and B lymphocytes don't work very well. We diagnose them in infancy because they come with chronic diarrhea and faltering growth. And I remember this because in one of my registrar jobs where I was working with an immunologist, on my first on call in the night at 3 o'clock in the morning, we have a new baby or a baby who's come in, a 6-month-old, for evaluation with some mild diarrhea. Child is well, we're about to send home, and the SHO says, the child is so small, it's like a doll. And the nurses went, this is such a beautiful baby, it's like a tiny doll. And you look and you think, this is at 4 o'clock in the morning, a very well baby, 6-month-old, but looks like a month-old baby, very cute. And I just go, you know what, it's 4 o'clock in the morning, I cannot think what to do with this child. You're well, you go home, come back next day morning, and we will do a lot of tests. So when I finished my shift, I made a list of, A4 size of investigations of this, faltering growth. And I come back the night and I ask, what's happened to that baby? And they said, well, that baby has SCID. And I said, well, that's the first one I've ever heard that's been diagnosed when I was there. What do you think we did for that baby that gave out the answer so quickly? It's there up on the slide. Full blood count, that's it. So you just did a basic investigation among all of it. Full blood count is the one that comes back within an hour or two. The lymphocytes were 0. Okay, so the child was sent away straight away for bone marrow biopsy and that. So most immune deficiencies, you do not need lots of tests. Simple tests, you just need to know how to interpret them. Okay, so SCID comes up quite often in your tests, because it is a medical emergency. You should not sit on these children. Okay. Just like if you have any child with jaundice, 2-week-old, and what's the one thing that's an emergency you should diagnose, the rest can wait? Biliary atresia. And why is it an emergency? The prognosis, exactly. The sooner you operate, the better the prognosis. The rest of the investigations can wait. Same thing in SCID, it is a medical emergency. Okay. So this is, as the name says, it's a bit more common, it's quite variable, males and females can get it, usually in older children, so teenagers tend to be, so you don't get this in babies, older children and adults, and they have low IgA and M. They also get recurrent infections, and when you measure their vaccine responses, they're quite low. But the clue in this usually is they're older children and they have immune deficiencies. I hope Digeorge syndrome you all heard, you know quite a bit about this. So I haven't put a lot in this, but it's for you to read. They have facial dysmorphic features, heart problems, low calcium. They have absent or not so working well thymus. So they also present with infections. So it's one of your differential diagnoses with any child presenting with recurrent infections. So let's come back to the 2 questions we saw in the beginning and see if you can work it out. So the first one, you have a 3-year-old girl. Parents are first cousins. She has eczema, severe recurrent chest infection. And she has numerous molluscum contagiosum. What are we looking at? Dockates, yeah. Yes. Okay. Let's see, the next one. You have a 14-month-old boy. He's got faltering growth. He's got a lot of infections. They're unrelated parents. And his IgG, M and A are all low. So let's see from the top. If you can't figure out, see if we can exclude anything. What can we exclude in this? Ataxia, telangiectasia. Yes, so he's not ataxic. He hasn't got telangiectasia. Combined. We could, okay. What else can we exclude? Complement deficiency, you think? What about SCID? We could exclude SCID. Severe combined, he's already 14 months, maybe. So he's a bit too old for this. They usually present within 6 to 8 months, SCID. So we excluded 3. So you've got Bruton's or complement deficiency. Which one could you exclude? Shall we ask Dr. Carroll how he would work this out, as he gave me this question? What were you hoping they would be able to do after this?
Well, it's a boy, so that's giving you a clue, isn't it? You're always looking at the sex of the child, I think, don't you, Josie?
I do, yes.
Yeah, so
You think
that,
male?
what's the inheritance of Brutons?
Excellent.
So we're on to a bit of a winner there, maybe we're on to a bit of a winner there. I would say complement deficiency is not going to give you low immunoglobulins as well. So we've kind of, I mean, SCID definitely not, and CVID almost certainly not with all low IgG, GM and IgA. So the most likely is going to be
Tricky. That's a bit harder one, I thought.
But also important that when you get to the exam, you may not be able to pick the right answer. Do not despair, because in clinical practice you may not be able to pick the right answer. You've just simply got to narrow the field as best you can. There will be a best answer. You might get down to the, well, it's one of these two, so let's have a go. And remember, always guess. If you don't know, don't leave a blank. People do every sitting of the exam.
Okay. Sorry, yes.
So why is not combined immunodeficiency?
Combined variable immunodeficiency. Could be, but wouldn't like to begin IgG, IgM and IgA all being low.
But in the slide, we say that all of them will be absent or no IgE, IgM.
Let's go back.
The slide of the
CVID, isn't it? This is where we are saying. So they can be low, but what we said was they're either older children or adults. So you're going towards that one.
And they don't tend to be as low. I mean, I'm
Yeah.
really sorry, because that is kind of, that's almost a,
Yeah.
well, wow, we could get the lecture going on for a whole, the course could take 2 years to go through everything. So it's just a case of, well, narrow the field a bit. But CVID does tend to be older children again as well. So I think the fact that if you can remember Brutons is X-linked, that at least helps you. If it's a girl, then it's unlikely to be Brutons, yeah? But Brutons is relatively common as well, and relatively common, so we really nail it. There's plenty more you can read on that, and I can give you some more reading, kind of lists of places to go and look for stuff, if you want, at the end of the course. But that would be, to my mind, that second question, although I wrote it, is a little bit more AKP, but it was more a case of trying to say, do you know what, you've got no chance before you listen to the lecture. Do you know what, afterwards, you've got a better chance.
Okay. So, this is just to recap. If it's a neutrophil function problem, they usually come with abscesses and skin infections. It's usually X-linked. And we talked about if it's LAD, there's usually delayed separation of cord. If you have congenital neutropenia, they have low neutrophil count. They also have cord delayed separation, and they have faltering growth. And I think I have one more slide of this. So complement deficiencies, remember, they encapsulated organisms, yes. So that's the bit. If you have a child with high IgE, if it's autosomal dominant, it's hyper IgE. If it's recessive, it's DOC8 with viral infections. And if it's bruising, it's Wiskott-Aldrich syndrome. If it's very early onset, and if it's severe symptoms, it's likely to be SCID with low lymphocytes and low immunoglobulins. If you have a child who's likely to be at walking age, so has to be a toddler, who's ataxic and has telangiectasia, it comes up to AT. Okay. So this is a free paper online, so you can go and see. But this is the one that took me a while to write with an immunologist. And all you need to see is children that you asked with immune deficiencies, who you investigate. All you need to do is the first box, the top box. So, full blood count, differential count, immunoglobulins. May not be even lymphocyte subpopulations for the beginning. What you need to know is HIV, although it's not very common, you have to remember this. Any child with faltering growth needs to have a HIV test done. So in your exams, it's unlikely to be HIV because we don't see it that often here, as you see in other developing countries. But it's always worth, if you have a child with faltering growth to think, could this be HIV? Okay, so those are the tests.
Non-miss screening for any reason. So a very specific question is, did you have your normal screening bloods in pregnancy without Dad being in the room? And the second clue is they often have high IgG and IgM from the recurrent infections. But that's getting a bit AKP again.
I was going to say, because more and more is the ethics of it.
Yeah, but we're getting AKP.
Yeah.
We're deviating from the, we'll be here all day if we teach the AKP course at the same time.
Yeah.
But this, yes, just remember HIV as well. I know we talked about immune deficiencies, but just remember that bit. Okay. So this is a very brief slide. There isn't much for me to say. You just have to know this. I only put one slide for this type 1. The rest are all in a column. So type 1 hypersensitivity, hopefully you all know. It's an allergic reaction.
You all know it.
You should know.
You all know. You all guess type 1 hypersensitivity for all hypersensitivity reactions all the time. So we know you know type 1.
So it's very quick. Sometimes can happen for a couple of hours. And all the immunoglobulins are normal. Okay? And this is, you can find this in any textbook or even Googling it, I think.
And this is the one you don't know. Okay?
But you need to know.
I know you don't know. So this is the slide to take a picture of.
There is no way to remember this except looking at it again and again. There is no easy way, but you just need to know this. It does come up in questions. What type of hypersensitivity reaction is this? You just need to know the list. So I think in the book that's there,
Yeah, in the book, yeah.
in this book, so if you go to that infection and immunity chapter, there are about 3 questions in the end, and these are the answers for this. So it's almost everything that we have covered today, but let's see, I think I've just got those 3 questions. Let's see if you can pick up the answer for it. A 9-month-old boy, IND of perineal abscess, Staph aureus has come up. He's 4 months old. He had osteomyelitis of left humerus. So he's got abscesses. Yeah, chronic granulomatous disease, likely. Yeah. So the next one, 2-month-old girl, tachypnea, respiratory distress, hypoxia, chest X-ray shows some changes. She's got pneumocystis. She's got faltering growth. And she's got candida. HIV.
Good thinking.
Very good.
20% young, and they've got really bad faltering growth, really representation. What are you thinking of?
SCID. Yes. Okay, last question. 5-year-old boy with an OT, recurrent otitis media, grommets, allergic to peanuts. Otherwise, well, his growth is normal. Would you investigate him? Yeah, you do some immunoglobulins. Let's say parents ask, he's getting a lot of infections. His IgA is a bit high. Yeah, could be a normal child. Could be raised IgE. But yes, depends on the answers you get, isn't it?
Atopy.
So there, atopy. So it could just be atopy. Yeah. I think those were your answers in this. Okay. So summary. This is the final slide. If you have faltering growth, if you have that spur, it suggests immune deficiencies. Know all the syndromes we discussed now. In the exam, look for your pattern of infections. Where is it coming up? See if the organisms can give you a clue, if it's very unusual. So look at it. Look at the age, like we talked about, and think of HIV. Right, any questions?